పీపీటీ కనిపిస్తుందా నీకు? కనిపిస్తుందా? రికార్డింగ్ రాగానే వీడియో స్టార్ట్ చేయండి ఒకసారి. ఓకే.
Hello, good afternoon. Today we are going to talk about complications of supracondylar fractures. Yeah. Good afternoon. Today we are going to talk about complications of supracondylar fractures. Supracondylar fracture is the very most common fracture in children, and it is an emergency where you need to operate or you have to do an immediate reduction, because it is not attending this fracture leads to many complications which we are going to discuss today. So the mechanism of injury is usually an outstretched hand with an hyperextension where the elbow gets hitched into the olecranon and fossa, and then it breaks over the supracondylar area. Sometimes it will be comminuted also. There are, when it comes to the classification, there are 1, 2, 3, 4 types of supracondylar fractures. Most common complications we see in type 4, where there is highest displacement of the fracture. So complications can be divided into two types. One is immediate and early complications, often related to the injury. First and foremost is the neurovascular injury. So whenever there is Gartland type 4 injury, so the humerus get displaced very severely anteriorly, causing a kinking option on the kinking force on the brachial artery and median nerve. So what happens in these fractures, after you reduce it, this brachial artery might get entrapped into the fragments. That is one option. Second option is it might get injured while that at the time of trauma. So that means there is transection of the artery. So whenever the patient comes to the ER, first we have to check the pulse of the radial pulse. If radial pulse is present, we take them to the OT, and then we completely reduce it and check for the pulse. If there is no pulse after reduction, then you have to remove the K-wires. Again put it back into the remove the reduction and then retry the reduction. If even after by repeat reduction, if the pulse is lost, then we have to go for only open reduction of these fractures, because this brachial artery is getting entrapped in between the fragments and get compressed. So the second most complication is compartment syndrome. This is an immediate complication, a sequelae of injury. So after injury, there will be a lot of swelling in the elbow and forearm, which leads to the compression of the blood vessels. See in the above image, there is not much swelling, there is not much pressure. So collateral circulation is present. Here, what happens in after trauma, there is a lot of swelling, so which reduces the collateral circulation, leading to the compartment syndrome and loss of sensation and movements. The muscle gets necrosed. So in this type of situation, we usually go for above elbow amputation, or you have to do decompression. If the patient comes in the early hours of compartment syndrome, before the compartment syndrome has set in, you have to go for decompression. So Volkmann's ischemic contracture is one complication what we see in children because post supracondylar fractures because of the compartment syndrome. This is a sequelae of compartment syndrome. So whenever there is a compartment syndrome where you have not treated it properly, slowly the muscles become tight, necrosed, and then they become tight, spasmodic, and all the nerves will also gets damaged. So there won't be motor sensation. Motor sensation is lost, and patient won't be able to move the hand. Even if he is able to move, he will be able to move only restricted movements, because muscles are tight and they are not sliding. Whenever you make a movement, muscles must slide to get full range of motion. But here in this case, it won't happen because the muscles have become tight and they are not functional. So in this case, what you do sliding osteotomy. Either you reduce the length of the forearm, and another thing is what you do slide, muscle slide. So you remove from the forearm attachment of all these muscles and then slide. They make them short so that there is some excursion of the muscle to get the movements. So pin site issues after surgery, you always face pin site issues. The pin tract gets infected. Also, stiffness might develop post surgery because the patient doesn't do proper physiotherapy. Then you might get stiffness. Whenever there is a stiffness, what you have to do, you have to go for a release of the stiffness, or you have to go for a mobilization or anesthesia, and then mobilize the elbow. So there is other than this early complications, you have overcome all the complications, but you have treated him. But most of the times you might face with the late complications, often related to the healing and malunion. Usually supracondylar fractures doesn't go into non-union. If they usually, most commonly they go into malunion. Malunion is one of the malunion is cubitus varus, that is gunstock deformity or cubitus valgus in this. Okay. So cubitus varus or gunstock deformities, post-injury, your elbow gets deformed like a gun, 303 rifle gun shape it takes the elbow. So that's why it is called a gunstock deformity. In this, you have to do osteotomy here. The distal fragment is rotated and it is in varus. So you have to do osteotomy to correct this deformity. So recurvatum deformity, where you see this, see the elbow gets hyperextended post-injury. See, in C it is normal, in B it is hyperextended. Myositis ossificans is the most common complication also in elbow fractures because of the tissue damage, surrounding tissue damage. So there is a pathological bone deposition which leads to restriction of movements and then loss of ROM. And if there is any myositis ossificans, that is you can consider it as bad outcome because the baby loses all its movements. So sometimes it might be repeat linked to trauma or maybe it linked to some genetical issues with the baby. So we cannot know, but the treatment is indomethacin capsule for 6 months or 8 months till the ESR becomes normal. Sometimes we give indomethacin for even 1 year also. There is no other medication, and also we give sometimes osteophos or rhizophos we give them so that bisphosphonates to reduce bone formation. When the when the myositis ossificans is matured, completely ossified, then only you can go for excision of the myositis ossificans. Thank you.